Welcome back to our conversation. In this section, we will be discussing the diagnosis of COPD. So Neil, in your opinion, what is the greatest barrier to providing optimal care to patients with COPD?
Actually, Ben, I think there are two big barriers to providing optimal care. Number one is recognizing this disease. It's an insidious disease, it builds up over time, and patients don't really recognize that they've got something serious going on, and clinicians don't always pick up on it as fast as they should. So that's barrier number one, diagnosis. Number two is then following good guidelines in managing these patients. There are a lot of options out there for these patients, and we need to be following the guidelines in providing this kind of care.
Well, regarding the diagnosis, as a physician assistant working in a primary care practice, how can I determine which of the dyspneic patients that present to my office have COPD and why they have COPD?
Well, that's an important question because, as we discussed earlier, it's a very common presentation in primary care and internal medicine practices. So history is absolutely critical. History is absolutely critical. Progressive dyspnea with smoking should really focus everyone's attention on the possibility of COPD. A chronic cough is a hallmark of the chronic bronchitic phase or type of disease. And a history of exacerbations is really very important. These episodes where they come down, they may think it's just chest colds, but in fact, it's a more serious inflammation, acute inflammation of an already chronically inflamed airway. When you examine these patients, you often will hear rhonchi or wheezes indicating obstruction of the airway. You may see hyperinflation on exam. These patients, because of the collapsing airways, can't empty their lungs, and the lungs become what people often refer to as barrel-chested. In more severe disease, with hypoxemia, they may actually become a little bit cyanotic. Spirometry is really key, and we'll talk more about that in a few minutes. But as I said before, spirometry only measures big airway function, and it can sometimes miss the emphysematous forms, the pure emphysematous forms of this disease. We can go on and do fancier things if the diagnosis is not immediately clear. For instance, the pulmonary function laboratory can be used to measure lung volumes and the hyperinflation that exists in these patients. The diffusing capacity can also be useful in assessing gas transfer. Blood gases or pulse oximetry can be very important in assessing the gas exchange properties of these patients. And this is important to do not only at rest while they're sitting in a chair with you, but during some exercise and sometimes with sleep. Sleep disturbances can be a real issue in these patients. And then, as I say, if the diagnosis is not really clear, other things that cause dyspnea, classic things would be things like heart failure, metabolic processes and the like, also need to be ruled out.
I'd like to discuss a case study with you to help illustrate and emphasize some of these key points. So we're going to start out, this patient name is Ms. W. She's a 59-year-old Caucasian female who presents to our local clinic with a 2 to 3 week history of worsening episodic dyspnea. She states that it was initially noticed only during exertion, but has become more noticeable with progressively less exertion and even present at rest. She reports having these episodes 1 to 3 times per year during the past 3 years, but she's noticed that a mild occasional productive cough for the past 5 to 6 months. This cough was described by the patient as initially being insidious onset in the early morning with sputum production, but now it's progressed to occur persistently throughout the day. She's had no fever, no chills. There have been no lower leg edema. There's been no chest pain. There's been no nausea or vomiting. She's awakened by the cough a few times at night during the past week and is concerned because the illness is recurring more frequently. In the past, she's been treated with a variety of medications, including oral and inhaled corticosteroids, long-acting beta-2 adrenergic agonists, and antibiotics, all with some degree of success. When asked about any changes in her symptoms over time, she relates that they used to occur only during the winter months, but now they occur year-round. When asked about if she exercises, she reports that she used to walk 2 or 3 times a week with the neighbor, but can no longer keep up because of her increased dyspnea. So instead, she now walks only about once a week. And she attributes this, like all patients do, to old age. Her past medical and surgical history includes hypertension. Now, there's some degree of questionable osteoporosis. She can't remember, but she says she's had several fractures secondary to simple falls or trauma. There's been no workup performed, and her last orthopedic visit was 4 months ago. And she was instructed at that time to follow up with her primary care provider. And of course, she has not done so at this time. She's had an appendectomy, she's had a cholecystectomy.
So this is a pretty classic history for somebody who likely does have chronic obstructive pulmonary disease, the progressive dyspnea, the cough. I find it interesting that she responded to bronchodilators and even inhaled corticosteroids or maybe oral corticosteroids in the past. So your index of suspicion is high. I think one of the things in the history that's important is the issue of sleep. I say that because sleep disturbances are common in COPD, and these can range anywhere from nighttime desaturations to nighttime hypoventilation to coexistent obstructive sleep apnea. And these symptoms can contribute to the feeling of illness and poor function that these patients with COPD have. So I would also, I think, I would emphasize that in taking history, that one asks about this problem, if there is one, of sleep disturbance.
Okay. In her family history, her father died of an MI at age 49, and he had a history of diabetes, hypertension. He was an avid smoker. Her mother is still alive, and she has severe arthritis. Now, she has a history of COPD. Also heart failure. She has 3 healthy younger siblings. She's married with 2 children. She smokes 1.5 packs per day for 30 years. She owns her own beauty salon. She drinks 1/2 to 2 glasses of wine for dinner only. There's no illicit drug use, and she does not do any other exercise other than her walking. She takes lisinopril, metoprolol, hydrochlorothiazide, and she's not allergic to any medicines. So my next question would be, in a patient with this type of clinical presentation, what would you consider to be an essential assessment of symptoms to include the medical workup?
So we've got the progressive dyspnea, we've got the productive cough, and now you've added the all-important smoking history. This triad, if you will, screams COPD at you. We haven't established the diagnosis, but it certainly should be up at the top. I discussed the issue of sleep disturbances, which may complicate the issue, but we need to move on to think about perhaps other diseases that might mimic this. But as I say, this certainly smacks of COPD.
Okay, so here's the results of her physical exam. She's obese, she's alert, she's in no acute distress, she's well-oriented to person, place, and time. She's very cooperative and speaks in intermittent broken sentences where she has to catch her breath every now and then. She weighs 225 pounds, and ideally she should be around 146 or less. She's 5 foot 4 inches or 64 inches. Her BMI is 38.6, and she should be around 24, so she is considered obese. Her temperature is 98.2 Fahrenheit. Her blood pressure was 175 over 92, but she states she hasn't taken her medications today. Her respiratory rate is 22. Her pulses are regular with the 92 beats per minute. They're equal on both sides and throughout. She has intact peripheral pulsations. The pulse oximetry was 89% on room air. On head and neck, she has noted arcus and there's a nicotine stain on her lips, of course, with no conjunctival hemorrhage and no pursing of the lips. Her neck veins are without jugular venous distension. Her chest wall, there's some brownish pigmentation with no scars or chest wall tenderness. There's bilateral limitation in the chest expansion and an increased anterior-posterior diameter. Her heart has regular rate and rhythm without murmur, gallops, or rubs. She has no bruise noted. Her upper limbs have fine tremors, but there's no clubbing. Her lower limbs have no pit and edema noted. So at this point, what further investigations do you think would be appropriate?
Yeah, well, your physical exam brought out several important points that, again, lead us down this COPD pathway. The nicotine stain on her finger is a good one. You describe a barrel chest or an increased AP diameter, again, reflecting the air trapping that occurs in this disease. I found it interesting that she has a pulse oximeter reading of 89%, which, as you know, is not normal.
Right.
And hypoxemia is clearly a manifestation of COPD. It usually occurs more in really severe forms of the disease, but alerts us to the fact that we've got something serious going on here. And again, we haven't totally ruled out other problems for it. So I think we need to do a bunch of things on her. Because COPD appears to be at least in my mind, the #1 diagnosis, spirometry is going to be important to document it. I think other routine evaluations that we do in patients with unknown dyspnea also should be done. CBC, is she anemic? Does she have a white count abnormality? Electrocardiogram to assess cardiovascular function. Chest x-ray would really be important to do here at the beginning. And because she's got this pulse oximeter problem, or abnormality, I should say, I think we need to pursue that further. Does it get worse with exercise? And maybe even consideration of looking at it during sleep. So depending upon the results of these studies, we will either firmly diagnose COPD, or perhaps these evaluations may lead us down another path.
Okay. So the provider of this patient ordered a battery of lab work and obtains a chest x-ray, which is read as normal. The CBC and blood chemistries, including LFTs and BNP, were all normal. A spirometry study and a post-bronchodilator study demonstrates that her FEV1 was 58% of predicted, her FVC was 87% of the predicted, and her ratio was 48%. So what is the importance of the spirometry in diagnosing COPD, and how can it be utilized to differentiate COPD from restrictive lung disease or asthma?
Yeah, well, this spirometric pattern you've shown us nails the diagnosis. She's got the classic pattern. So what is spirometry? We've touched on it already. Spirometry, a little piece of trivia for our viewers, is the oldest clinical test still in use today, first described in 1846, so it's been around a long time. It's a fairly straightforward measurement of how much gas you can fill your lungs with voluntarily and how fast and complete can you empty it. So a fairly simple test. A little caveat, however, is that it really requires a good technician to do it properly, because patient cooperation is absolutely essential. There are three key measurements that you've already alluded to: the vital capacity, the maximal amount of gas you can get out. The FEV1 is what comes out in the first second, the forced expiratory volume in the first second, and the ratio of these two. So the vital capacity measurement is, well, actually the vital capacity and the FEV1 measurements are both based on predicted values. So big people have bigger vital capacities, little people have little vital capacities. And we use age, gender, and height to predict them. And generally we say if you're above 85% of the predicted, you're normal. Now the ratio of the two actually is pretty constant across all ages, genders, and heights. And a rough rule of thumb is that the ratio between the two ought to be 70% or greater. So vital capacity, FEV1, and the ratio. In obstructive lung disease, like COPD, the patient can get it out eventually. So the vital capacity is normal, but they don't get it out very fast. And as a consequence, the FEV1 is quite low, and the ratio thus is quite low, just like our patient. The other common diseases we think about in the lung are what are called restrictive diseases. Restrictive diseases means the lung is small. So the vital capacity then is going to be reduced, and the FEV1 is going to be reduced along with it, but the ratio between the two stays normal. So again, the classic findings in COPD are a normal vital capacity or near normal vital capacity, a low FEV1, and a low ratio between the two, just like our patients. Now, sometimes we do a bronchodilator response, which can give us a handle on how effective bronchodilators may be. I don't think that test is mandatory, but clearly it can be used as a piece of information to assess your patient.
Okay. So if we're utilizing the GOLD criteria shown here, Ms. W has a moderate COPD. Her FEV1 and her vital capacity are less than 70%, and her FEV1 is between 50 and 80% of the predicted. Do you agree with this?
Yeah, on the GOLD criteria, that's where our patient falls. She's at, 58%, I think, post-bronchodilator, and her ratio is low, the classic findings of COPD. So we've talked a little bit about these GOLD guidelines before, but just to reiterate, you get on the table, if you will, by having a ratio less than 70%, which she does, and then if your FEV1 is 80% of predicted, you're stage 1 or mild, 50 to 80, as we said before, is moderate or stage 2, less 30 to 50%, is stage 3 or severe, and less than 30% is very severe. And these do tend to correlate with symptoms, and they do tend to correlate with things like exacerbation risks, But as we mentioned before, it still is it's a test only of the bigger airways of the lung, and you can still have significant disease in the lung with obstructive airway physiology, especially in the small airways, that may not show up with a horribly abnormal FEV1. We need to go beyond just spirometry, but it's certainly a very important tool to initially assess a patient and stage a patient.
So since we have all this knowledge about this, what do you think are some of the most common errors in diagnosing COPD?
Well, the spirometric tests we've been talking about detect airway obstruction.
Right.
And the most classic example of airway obstruction is our patient here, COPD. But the other big disease that causes airway obstruction is asthma. And as a consequence, we have to go further than just the spirogram in assessing the asthmatic. Key differences in the asthmatic is our history. It's an episodic disease. It has clear triggers. It gets better. It responds quickly to medications. It's not a fixed, progressive, chronic, irreversible structure or abnormality in the airway. So asthma is a big one. As we said before, there are other things that cause dyspnea, as you know well. Right. Things like heart disease come to mind, anemia comes to mind, muscle disorders come to mind, metabolic derangements come to mind, that all need to be considered. Other lung diseases come to mind. But in this patient, with our clear pattern of obstruction, our clear pattern of smoking, our clear pattern of progressive dyspnea with cough, and our history, which I find interesting, of some reversibility with some of these classic medications, all, I think, tend to drive us to the diagnosis of COPD as the problem here.
Okay, so you mentioned earlier that the gold staging guidelines are being updated. Can you elaborate on this?
Yeah, I'm glad you brought that up, because I've been mentioning over and over again that the FEV1 is a good way to stage the disease, but it misses a lot of features of the disease. And the GOLD group recognizes this. Upcoming new versions of the GOLD staging system are going to include not only the traditional FEV1, but it's also going to include markers of dyspnea, and it's also going to include that all-important issue of exacerbation risk and exacerbation frequency.